Thanks so much for the opportunity to spend some time with you on Saturday morning. I was asked to talk about gene-environment interaction. Some of the other things that came up with the Q&A with Dr. Beck, we can address later if I don't touch on them in my talk today. And so the first step is what we've been talking about already. What causes Parkinson's disease? And this is a clue that environment was important. It's something that inspired me to be interested and actually get a PhD in this area. So this is a California story. This little picture we see on the right is a garage where people were making some designer drugs down in the Santa Clara area. And what they found was that people they took a little bit of a wrong turn in the illicit manufacture of these drugs, and people injected them, and they got something that was very much like Parkinson's, except it came on fairly quickly, and it was this little group of people, and they were able to get the drug that was manufactured and analyze it in the laboratory and figure out it was this thing called MPTP. And the people with MPTP-induced Parkinsonism had similar signs to Parkinson's, slowness and tremor. If you gave them levodopa, they got better. And they got some of the same side effects from levodopa. So that was like very exciting from a scientific perspective. I mean, we know that people with Parkinson's disease aren't, injecting drugs and getting it for that reason. But it led to, first of all, something you could use in the laboratory to try to understand certain mechanisms of changes in the brain that would be important to people with Parkinson's. But second of all, it led us to this whole idea that maybe there are other things that are environmental factors, that aren't inherent factors, that also might be causes of Parkinson's disease. And so that was really a big revelation and led to a lot of the things that I'm going to talk about in my talk today, work that I and my colleagues have done. And Dr. Beck talked about genes, and he made the same point that this slide makes, really, which is that this is maybe a little bit more current list of the genes, maybe not. But it points out that even the more common genetic causes of Parkinson's disease don't account for Parkinson's in most people. And in general, even if you do have one of these common mutations, it doesn't necessarily mean you're going to get Parkinson's disease. So the LRRK2 gene, for example, about 30% will get it. So there's 70% who don't. Why is that, right? And what we think is that it's because it's a mixture of genetic and environmental factors that are the reason. And so that led me to become interested in trying to understand the environment and work with my colleagues to do that. So this is an example. My topic today was I was asked to talk about gene-environment interaction. This is an example of kind of how we got to think about this idea of gene-environment interaction. So came up in the Q&A before. Head injury is something that's been associated with Parkinson's risk. This is something we call a meta-analysis or a combined analysis. Maybe try to walk around this way. My little pointer. Basically,
turn it around.
Oh.
I'm pointing at you.
I'm pointing myself.
There you go.
Thank you. All right, so this line is nothing's going on. If it's to this side of the line, it means if you had a head injury, your risk of Parkinson's increased, and if it's to that side of the line, it means your risk of Parkinson's decreased. So this is just a way we kind of judge, is something really happening in these big populations of people, and we're trying to look at a relationship between some factor and getting a disease. And so mostly everything's on this side of the line, so it looks like there's an increase, but not everything is, right? And certainly lots and lots of people get head injuries, but not everybody gets Parkinson's. There we go. So it's about a 3 times increased risk if you have a head injury. There's a lot of reasons in the laboratory that it makes sense. I won't go through all of those. But certainly it's not everybody with a head injury ends up getting Parkinson's. So why is that? And this is where the idea of gene-environment interaction comes in. So in this case, this is an example of some work we've done. The gene is alpha-synuclein. Now you heard about alpha-synuclein because that was the first gene mutation understood to be associated with familial Parkinson's. That gene mutation is exceedingly rare. You can kind of count the numbers of people who have it maybe 50, maybe 100, but probably no more than that in the whole world. So that's a very, very rare cause. But what we found out from studying those people is that alpha-synuclein is a protein product from that gene mutation, or from that gene, and it's really important to Parkinson's disease. When we look in the laboratory in the microscope, we see something that's called a Lewy body. And Lewy bodies are a way that you can be a pathologist and say, oh, this is somebody who has Parkinson's. That Lewy body is chock full of alpha-synuclein. So alpha-synuclein, this protein that seems to be really important, we're understanding a lot about it in terms of Parkinson's disease. So the gene we're talking about here is alpha-synuclein. The environmental factor is head injury, but we're not talking about that primary mutation. We're talking about what we call just a small variation, a little variation in the sequence, in the code, in that DNA instruction that's in that gene. And it just makes a tiny little change. Whoops, something keeps pushing it the wrong way, sorry. And here's what we see. If you just have that little tiny gene mutation, you may have like a 50% increased risk of Parkinson's. If you have the head injury, it may be a little bit more, 70%. But if you have the gene variant, it's not really a mutation, the gene variant or the head injury together, your risk is 1,000 times greater. So this is a classic example of gene-environment interaction. People who have head injuries, who also have that tiny little variation, it doesn't have much effect by itself, but you put those two things together and then your risk increases. So that's the concept, and this is really what we think is the basic pattern, not just about head injury, but in general, for people who have Parkinson's who don't have one of those primary familial inherited gene forms of Parkinson's. It's a combination of genetic susceptibility and then what happens to you in life, what you do, what happens to you, things like that. So environment, everything that's not in the gene. So it's kind of suggests that it's the combined effects, both genes and environment in most people, are really what is causing Parkinson's. So I'm going to give you a couple, this is just the summary, so this is something I like. Genetics loads the gun, but environment pulls the trigger. So you're kind of, you've got maybe a little bit of a potential, but for most people it maybe never manifests. For other people, there are things that we can figure out that maybe make it happen. And this is kind of the scientific slide cartoon that says, what could that be? And so one idea is a toxicant, something like the MPTP, or we talked about pesticides that you might be exposed to in the environment. Maybe somebody has a protective factor, so they're not absorbed very much, and somebody else doesn't have that factor, so they're absorbed a lot. Maybe somebody's body is very good at breaking down these chemicals, and somebody else is not so good at breaking them down. Things have to get into the brain to have an effect. For some people, maybe they get into the brain not very easily, and for other people, they get in fairly quickly. So all of those different factors, how your body processes or responds to these chemicals or other exposures, would be the reasons that some people would and other people would not get Parkinson's. So pesticides is one of the things that people have spent some time trying to investigate, partly because, going back to MPTP, the chemical effects in the laboratory of that compound MPTP, and also the structure of MPTP, were very similar to certain kinds of common pesticides that have been used and might be, in fact, environmentally present, and people might be exposed to them. So we were really interested in looking at whether or not pesticides might increase risk. And so as a big category, if you ask somebody, were you exposed to pesticides, maybe there's about twice the risk of having Parkinson's if you say yes to that question, yes, I had pesticide exposure. But anybody who knows pesticide is like hundreds of, thousands of different compounds, and they all have different chemical structures and different ways of affecting the body, and some of them, target certain areas and some others. So it's a huge category, and it's not very easy to make much sense of it. And not everybody exposed gets them. So this is a very first clue that there might be a gene-environment interaction. It came from some investigators in France who were looking at the health records of people who were farmers in France who got health insurance. And they sort of guessed that people were or were not exposed to pesticides based on kind of what their job description was. And then they looked at their genotype for this one gene called cytochrome P450 2D6, which breaks down certain kinds of drugs or chemicals that get into the body. And what they found is that people who are not very good at breaking down drugs or chemicals had about a 3 times greater risk of Parkinson's, and people who had the ordinary or the functional variation of this particular gene didn't really have an increased risk of Parkinson's. So again, another example suggesting gene-environment interaction is important here in pesticides. So my colleagues and I wanted to look at this, and so we were able to look at the agricultural health study, which is a large population of farmers and their spouses who are being followed prospectively through some NIH and EPA studies looking at other things like cancer. And we got to add in the Parkinson's part. And what we found was that Paraquat, which just so happens to look chemically fairly much like that MPT compound, was associated with about a 2.5-fold increased risk. And then in another population that we studied, which was just pulled from movement disorder centers and compared to people without Parkinson's, the same basic thing. So about a little bit more than a 2.5-fold increased risk in that population. And then what we were interested in looking at was a gene that would be responsible for the body breaking down or detoxifying this particular chemical. And what we found was the same basic idea. This is a gene called glutathione S Transference T1 or GSTT1. It's a protective gene. And what we found is that people who had the normal version of it did not have a higher risk of Parkinson's. People who had the missing gene, the mutation here is you just don't have it, don't have the active protein, had about a 13 times increased risk of Parkinson's disease. So again, a suggestion that gene-environment interaction is really important in mediating risk that's related to Paraquat. This is another study that we've been involved in, and this is looking at people who live in Alaska, Alaska natives, and understanding the relationship between their exposure, both dietary and environmental, to persistent organic pollutants. And these are, first of all, their subsistence farming or subsistence lifestyle in Alaska really relies on the land and sea creatures and marine mammals and things that they can harvest. And it just so happens that persistent pollutants are bioconcentrated, they're geoconcentrated in the northern environment, and then they're bioconcentrated up the food chain. So if you eat a lot of like marine mammal fat, you're going to get a liver, you're going to get a really big dose of persistent pollutants, so certain kinds of chemicals like polychlorinated biphenyls or organochlorine pesticides. So there's a report that suggested that Alaska, or the native populations in Greenland had a higher risk of Parkinson's. We were interested in looking at Alaska natives and also trying to see if that was true there and if we could figure out why. So we were studying, their basic lifestyle, identified, whether they had Parkinson's or not, and then we did blood tests where we looked at the levels, the concentrations of polychlorinated biphenyls and organochlorine pesticides, and also got DNA samples, and so we're able to look at the various genes that might be affected in metabolism. We took people from all over Alaska, and what we found was basically people who had higher blood levels of certain ones of these persistent pollutants. So HCB is hexachlorobenzene, which is an organochlorine pesticide. PCBs are polychlorinated biphenyls. They've been used in a lot of different electronics manufacturing and things like that. And they're persistent in the environment. They don't break down, so they just stick around. And then DDE, which is a breakdown product of DDT, but is environmentally persistent. And people with Parkinson's who are Alaska natives had higher concentrations of these compared to Alaska natives who didn't have Parkinson's. And then when we looked at a particular gene, and this is what's called an efflux transporter. So basically this spits out the bad stuff, right? So if a chemical sort of maybe could get into a particular cell, this kind of spits it out and protects against it getting in there, right? So this particular xenobiotic membrane efflux pump, which keeps things from getting into the brain, from crossing what's called the protective blood-brain barrier, has variations as well. And if you have a particular variation in that particular transporter and you're exposed to these particular chemicals, this one is, I think, the hexachlorobenzene blood level. Oh no, this is PCBs. What you see is about a 17 times increased risk of getting Parkinson's. So again, if your body's not very good at like protecting against a specific chemical, that might really increase your risk of Parkinson's if you're exposed to that chemical. And then we were interested in like, can we replicate this? Because we're just looking at this really pretty small population of Alaska Natives. So doing things over and over again is important in science because there are a lot of potential coincidences and you don't want to go too far until you're sure this is something to pursue. So we went back and we looked at the farmers who were really very different than the Alaska Natives in almost every regard, except for these exposures and genes that we're testing. And we found basically the same thing, that people who had exposures, in this case the PCB blood levels again, and this particular variant of the gene had 12 times increased risk of Parkinson's. So again, definitely a gene-environment interaction in this farming population. So we're looking at all the things that cause, and that's just like one list of them. There are also things that may be good, that may be, we call them inverse associations. So you have a lower risk of Parkinson's if we see this pattern in the population. It suggests this might be something good. Now this is a tricky one because over and over and over again since really the 60s, 1960s, it's been observed that people who have who are smokers are at a lower risk of Parkinson's disease. It doesn't mean people should go out and smoke. It's just, it gives us good clues for things we want to understand in the laboratory to come up with better treatments. But it's a really consistent observation pretty much around the world. And we also see something that makes it sort of more convincing is that, never smokers have the highest, this is new cases of Parkinson's when you're looking forward in a population, the highest rate, and heavy smokers the lowest rate of incidence of Parkinson's, right? So there are a lot of reasons maybe why this might happen, and the important thing is for scientists, smoking has a lot of bad effects, is for scientists to kind of understand that. But one thing to know is that there are a lot of possible gene-environment interactions that also have been suggested in this setting. And here's an example that's looking at one of the primary genes, so that LRRK2 gene that Dr. Beck talked about. This is a variant that's very common in Asian populations of the LRRK2 gene. And what it's associated with is about a 2-fold increased risk of Parkinson's if you have this particular variation in the gene. However, the smokers did not have an increased risk, and the non-smokers had a much higher increased risk. Now again, not to go smoking, but just so to demonstrate that even in these genes that have a pretty strong family inherited pattern, it's still modified by genes, right? And so gene and environment together are the things that happen, and environment can modify a genetic form of Parkinsonism as well in terms of your risk. And if you can modify it just sort of passively with environment, then you can think of ways to modify it with treatment as well. So this is another example. This is that same gene that we were talking about. This is an analysis that we're just about to send in for, hopefully for publication. And this is looking at non-steroidal anti-inflammatory drugs, so either ibuprofen or aspirin. And the reason we're interested in that is there's a lot of evidence that suggests that inflammatory processes are one of the things that maybe make Parkinson's happen, that there's kind of a cycle that gets triggered and then keeps going. And maybe if you can block or reduce that inflammation, maybe you can lower the manifestation of Parkinson's. So again, looking at a big population of people who have these LRRK2 mutations and whether or not they had a period in their lives where they used these non-steroidal anti-inflammatories regularly for like 6 months or longer. What we found was that if there were people who had that longer exposure, they had a lower risk. So this is about an 80% reduction. This is about a 50% reduction if people used anti-inflammatories, so 60% overall. So again, suggesting that you can really modify the effect even of a strongly related factor like one of these primary genes. So this is just a little cartoon. I won't be able to go into all of this, but we can talk about it later, of many of the different things that in many different populations have been suggested to relate to Parkinson's disease. So the higher risk related to the chemicals we've talked about, solvents I didn't get to talk about, but that's another story with a strong association. Air pollution, kind of a growing phenomenon that we think is also related. Metals, maybe, we're not so clear. And then things we can't modify but will help us understand, like age or male gender, which also slightly increase the risk. And then this slide is even more important in a way, because this is the slide that shows the things that lower your risk. And some of these are more kind of investigational than others. But I want to particularly point out physical activity, because one of the things that we know and that kind of increasingly is reproduced, and apropos of the break that we just had, is that physical activity, first of all, lowers the risk of developing Parkinson's disease. Second of all, if you have Parkinson's disease, you tend to have a better clinical course if you're really active and if there's a certain amount of physical activity. There's one study that looked at the simplest thing, like just whether people walked or, during their commute to work, whether they did something that involved walking, whether they were just in the car all the time. And just that little bit of sort of passive activity lowered people's subsequent risk of getting Parkinson's disease. So a little is okay, more is better, but don't be deterred from starting to be active. I think that's a really important point. So just to put it all together, genetic Parkinson's is rare. Purely environmental Parkinson's, as far as we think, is probably rare. And really it's going to be the combined effects of genes and environment that probably have a little bit of an individual equation that really help us to understand who gets Parkinson's. This, to my mind, is really hopeful. We have scientific ways of identifying and targeting genes, but if it's multiple effects of multiple small genes, that could be hard. But we can change the environment too. So if we can identify these and target things like this, that could make a big difference in terms of Parkinson's disease. And just to make a point on that, it was 1817 when James Parkinson's first described Parkinson's disease, and that was the beginning of the Industrial Revolution in the UK, where he was a practicing physician. So, it doesn't prove anything, but I think it's an interesting association. So, can we prevent PD? This is from our work, and it's just a sort of an example, a possible proof of principle that maybe we can. So primary prevention means you take away the cause, and then nothing ever happens. You don't even have to worry about slowing or stopping disease progression. It just doesn't come to pass. And so, examples of how people might do that, it's like, our drinking water gets fluoride in, and that really reduces dental caries, for example. There's some big public health things that we do. They put certain vitamins in bread and things like that sort of help people avoid vitamin deficiencies. So there are some big ways that these things can be addressed. This is an example, again, back to the agricultural health study, the farmers there, and looking at 2 chemicals that were associated with Parkinson's increased risk in that population. I mentioned one of them already, Paraquat. And what we looked at was whether or not farmers used what's called personal protective equipment when they were mixing or applying pesticides. And so that means gloves or respirators, or if you had a spill and you were wearing something, did you stop and wash off, or did you just kind of, walk around with the pesticide kind of in touch with you or your body? And what we found was the farmers who did use personal protective equipment did not have an increased risk of Parkinson's. So above this one is an increased risk, and this is not. So they didn't have an increased risk, whereas farmers who did not had about a 4-fold increased risk. And when we looked without thinking about this factor, it was about a 2.5-fold increased risk. Similarly, for another pesticide, permethrin, we found the same pattern, and it was even a little bit more. So this is just a simple observation. That's something very simple. Removing the pesticide exposure can make a really big difference in terms of the risk of Parkinson's, even in a population who are pretty heavily exposed through their occupation. So it suggests that cleaning up or other ways of addressing the environment would be something useful for all of us. And so I'm going to stop there with that talk and just take advantage of having the stage for a minute to talk about two things that are research studies that are related to some of the other things that have been talked about today, but maybe not specifically this topic, but they're coming up in our group at UCSF. The first one is a study we're just about to start, and it's looking at something called the microbiome, or the microbiota is a bigger term for that, and whether or not it can change the way people with Parkinson's respond to medication. So, as you probably, this is a popular topic, there are bacteria everywhere on your skin, in your mouth, in your GI tract, and increasingly we're understanding, first of all, there are tons of them, and second of all, they really have a lot to do with kind of what happens to us, how we process foods, how things like that happen. They can really change. This is a famous example of these two mice, which are genetically identical, but have a different GI microbiome, and so one of them is obese and one of them is not, based on the bacteria in their GI tract and how that leads them to be able to take in and metabolize foods. So microbiome is probably interesting. It's a kind of a frontier area for study. It's kind of new. For Parkinson's disease, people have looked at comparisons between people with Parkinson's and people who don't, and there are microbiome differences between those. There's a question about whether or not that may mean that it has something to do with risk for Parkinson's, and that's not the question we're going to be addressing right now, but it's an important one. It's a tricky one. But we're going to start with something much more focused, which is, can we change the way people's response to levodopa occurs based on changing their microbiome in their GI tract? So basically, we know that bacteria in the GI tract can have an enzyme that breaks down the levodopa. And if you metabolize the levodopa and turn it into dopamine, and that's happening in the brain, in the area of the brain that you want it to be active, that's a really good thing. If you do it in your intestine, it doesn't even get into the bloodstream, and it can never get to the brain, and so it doesn't have any effect. So there are certain bacteria that are in the GI tract that actually metabolize levodopa and turn it into dopamine in the GI tract. Okay, so we don't want that to happen. And so what we want to do is stop this wearing off of levodopa that many people are familiar with. So you take the medicine, you get a good benefit, then it drops down and the day goes like this, good effect, bad effect, good effect. We'd like it to be more like this, continuously good effect, right? And so what we're hoping is that maybe by changing the composition of the gut microbiome, we can give people a more continuous response to levodopa. And so we're about to do a study that asks these questions. Are there differences in the microbiome that relate to differences in people with Parkinson's? And can we change motor fluctuations by altering the microbiome? So there's a particular kind of an antibiotic that only works in the GI tract. It doesn't get into the system. And so it could kind of, quote, reset the microbiome. So that's a hypothesis. We don't know if this can work or not, but that's a hypothesis, right? So the idea is people who have fluctuations with off time would be, first of all, studied just to determine the fluctuations and what their personal pattern is. Then some of them will be treated with this active antibiotic that would change the microbiome, and some of them would not, would be the comparison group. So they'd get a capsule, set of capsules, but they wouldn't have anything active in them. And then we'd make the comparison between those two groups of people to see if we have better response in the people who have had the altered microbiome. So this is a study we're just about to begin at UCSF, and I have a few flyers I'll put out. If anybody here is interested, if you know anyone who's interested, you can call and see if that's something you want to pursue further. You can talk to our coordinator and study team. The other thing I wanted to bring up, and this came up too in our earlier conversation with Dr. Beck, is another study that we're beginning. This is a partnership with the Parkinson Foundation. So it's a big study. It's funded by NIH, by the Aging Institute. It's a partnership between UCSF, the Parkinson Foundation. It's bringing together neurologists and people who focus on bone disease and osteoporosis. And basically, we're targeting the fact that people with Parkinson's have a very high risk of fracture. It's like 2 to 4-fold increase for people with Parkinson's. Osteoporosis, weak bones, is much more common in people with Parkinson's. And hip fractures are higher in both women and men with Parkinson's, and even higher in people who are over the age of 65. It far exceeds sort of the threshold for treatment that the National Osteoporosis Foundation represents as important. And yet very, very few people with Parkinson's are ever treated for low bone density or to protect or prevent fractures. Yet we know that fractures in people with Parkinson's increase disability, people lose independence, it's harder for you to exercise, more people who have a fracture, and especially a big fracture like a hip fracture, may end up not being able to stay in their homes. So a fracture is a big deal. And when you have a fracture and you have Parkinson's, it's even a bigger deal. So we want to prevent that. We don't want that to happen. So people, this is what I just said, they have very low rates, and yet, you know, people like me, neurologists, we don't treat osteoporosis. And people with Parkinson's, there are oral medications, but people take so many medications, it's hard to take these medicines. A lot of them, you take them and then you have to like be upright for some period of time and not eat, and that interferes with your Parkinson's meds. So compliance, even if they're prescribed, is very low in people with Parkinson's, lower than it is in other people of the same age. So what we're going to do is test a drug called zoledronic acid, which works the same way as the oral medications, but you give it once every 2 years. So it's very simple. You give an infusion, and then the effect lasts for a long period of time. The other thing that we're going to do to kind of reduce the barriers is this is a completely remote trial. So you don't have to go to the doctor to be involved in this clinical trial. We're going to study 3,500 men and women with Parkinson's disease. We're going to screen them. First of all, the names will be referred to us with their permission from either big networks, people who are established for research based in healthcare systems, or through doctors from the Parkinson Foundation Centers of Excellence or the Parkinson Study Group. They will be screened by the Parkinson Foundation call center for eligibility and interest. If people are interested, they'll sign their consent to participate online. People who aren't already being evaluated by a Center of Excellence doctor or Parkinson's expert will then be screened by us using telemedicine, just to make sure they really have Parkinson's and they're really eligible. So we'll do a telemedicine assessment of them. If they indeed have Parkinson's and they're eligible to be involved, then a nurse will go into their home and will give them this infusion of zoledronic acid or the comparison inactive drug. And then we'll follow people over 2 years to see who has fractures and who does not. So it's a very large, over the course of the US, completely remote clinical trial. No doctor's office visit is required. So it's really important for the outcome. We want to prevent fractures in Parkinson's, but equally important because of a couple of other things. It represents, I think, a really important partnership between, you know, experts like us, academics, and the Parkinson Foundation. So it's kind of a novel way of taking advantage of all the different areas of expertise and resource to conduct a clinical trial. And second of all, having a clinical trial that's completely remote may help to overcome some of the barriers of getting enough people to be involved in trials, because that's a big limitation to drug development in Parkinson's. Not everybody who is eligible for a trial participates. Only about 10% of the eligible people participate in a trial. So we can't develop drugs if we don't have volunteers participating. So that's another very important, if this works, we can apply it in other kinds of settings. So this is just the basic pattern for that, right? We get the names of the people from the various systems that they get screened by the Parkinson Foundation. They get referred to us for telemedicine assessment. And then the research nurse goes into the home and gives the treatment, either the active or the placebo. And then we just follow for 2 years. And what we hope, of course, is the people who got the active drug have many fewer fractures. So that's what we're going to be assessing. So that's really the end of what I wanted to say. I wanted to acknowledge all my colleagues at UCSF and in the movement disorders group who are contributors to all of these studies. And also thank the sponsors of all of this research, but most particularly, I want to thank people who are research study participants and their families. It really takes a village to be involved in research. If we didn't have you, we'd never learn anything, no matter what we do in the laboratory, without working with people with Parkinson's and their families, we'll never learn anything. So thank you so very much.
Got about 5 minutes.
Okay. Yes.
Yes, you've shown that smoking reduces the risk of Parkinson's. Does anybody look at nicotine?
So people have tried to look at whether the nicotine patch could slow progression in Parkinson's disease. And that particular study, which had maybe a lot of different questions about it, I do not believe has shown that it was effective in people who already had Parkinson's to slow progression. I think people are interested in thinking about, are there ways we can understand this or understand the mechanisms of nicotine to be able to come up with better treatments. But it's kind of back to the laboratory a little bit right now. Yeah. Yes.
Has there been some correlation between Agent Orange and Parkinson's?
Yes, so the question is, that Agent Orange and Parkinson's, has a correlation been shown? And the answer is yes. So we did a study. So Agent Orange has 3 components, and a lot of people hear about dioxin because that's the one that has a strong association with cancer risk. There's another herbicide that's in Agent Orange called 2,4-D. Our group did, yeah. And so our group did a study looking just in people with Parkinson's, not people with military exposure, and independently found that to be associated with greater risk. And kind of at the same time, other people were looking at military veterans who had served in the Vietnam era in certain theaters, and looking at the relationship between Agent Orange and Parkinson's risk. And so the Veterans Association has determined that there is sufficient evidence to give people a service-related disability for Agent Orange exposure if they have Parkinson's disease. Yeah.
No.
I don't think so. Yeah, yeah. It's I don't remember its brand names, but yeah. Glyphosate is what's in Roundup, right? So glyphosate or chlorophosphate maybe is what's in Roundup, yeah. Which also in certain studies I'll say has an association with Parkinson's, but yeah, yes.
Are there any side effects to the ZA infusion?
Yeah, so the side effects of the zoledronic acid infusion, so there are some, and in any study, people are signing up for them. We go through all this and you get to think about, do I want to take this risk or not? Because involvement in research involves some risk. Sometimes it's relatively little. When it's an intervention like a drug, it's just inherently going to be a little bit more. So probably the most frequent side effect of zoledronic acid infusion is that probably maybe 30% or so of people who have this infusion get kind of a transient flu-like syndrome. So you feel sick for a couple of days and you feel like you're kind of flu-y afterwards. You can give some drugs to kind of block that, like Tylenol or ibuprofen before you start the infusion. That lowers it a little bit, but still some people have that effect. It's not harmful, but it's unpleasant, right? That's the most common. There's a very, very rare side effect associated with this whole class of drugs, which is a kind of an atypical kind of fracture that can happen to a very small number of people. That's the one that actually got a whole lot of press because of recognizing the association. The actual frequency of that is extremely low. But that's kind of the range of the kinds of side effects that can happen. People who are planning dental work and things like that shouldn't take these drugs because it can increase another side effect called osteonecrosis of the jaw, because it affects the way the bone is kind of, working and solidifying itself. So we need to make sure that the people who are enrolled in the trial are eligible and wouldn't be at risk for those kinds of side effects. Yes, way in the back.
Yeah, what was going to ask, since we're looking at fractures, non-fractures, are we going to look at a particular group? We know that the younger group with their osteoclast and blast is totally different than when you get to an age stage that changes.
Yes.
So we're going to be looking at different groups.
Yeah, so in this particular study, we're going to be looking at people age 65 and older, and there'll all be people who have Parkinson's disease. And the comparison, when we select people to come into the trial, people will just be randomly assigned to the active drug or the non-active drug, but generally with a study is 3,500 people, will generally end up with about equal numbers of other characteristics in the two groups, the active group and the comparison group. So about equal numbers of men to women, and 65 and older, probably the age distribution usually balances out pretty well to be pretty similar between the two groups. So we try to look at that as we're accruing people into the trial to make sure that those two groups are pretty balanced any way that we think might be influencing the result. This way in the back there.
One more question, then we'll save
Okay,
this for.
yeah.
So just a question about the smoking studies. Everything I've ever read was poorly age master controlled, and we know there's a shorter life expectancy in people who smoke. What are your thoughts on that?
Okay, so there are many, many studies. There are more than 50 studies looking at the relationship between tobacco, cigarette smoking, oral tobacco, and risk of Parkinson's disease. And many of these were what we call prospective cohorts, where they're looking forward and making adjustments in terms of the kinds of comparisons you can make for other causes of mortality. So I think the association is pretty robust. It's not that I'm recommending smoking, but I think this has been looked at over decades in populations around the world, and it seems to be a fairly solid finding. So I'd be happy to share more references with you and help you look at that.